So look, it's lovely to be here and to be among this gathering today. I think so many patients and families are doing it in relative isolation, and they do come and see clinics. But to have everyone here, as many people as possible here today and sitting together, I think is wonderful. So let's go through things. As Dominic said earlier, motor neurone disease is known here, but if we were having this talk in Chicago or Cincinnati, we'd be using the expression ALS or Lou Gehrig's disease. Who was Lou Gehrig? Well, Lou Gehrig was one of the great baseballers of his time. He played for the New York Yankees. And at the midpoint of the 1938 season, Lou Gehrig's performance began to diminish. At the end of that season, he said, "I tired mid-season. I don't know why, but I just couldn't get going again." Throughout his career, he'd been considered an excellent base runner, but as the 1939 season began, his coordination and speed had deteriorated significantly. A reporter said, "I think there is something wrong with him, physically wrong, I mean. I don't know what it is, but I'm satisfied that it goes far beyond his ball playing." A remarkable piece of observation by someone watching someone very, very closely. Lou Gehrig was diagnosed with ALS, or motor neurone disease, on his 36th birthday. So how can a sense of life be preserved or nurtured in the face of this disease? I think that's a question that is on everyone's mind, really, throughout the course of any illness, and certainly this particular disease. Every person with motor neurone disease and every carer faces this question. How can we preserve the sense of life and maintain a sense of life through this time? Much of the answer to this question is deeply personal. Every person would have their own answer to that. What is important to me? Whom do I love? How am I going to fill my days? I'm going to miss many things, but what is the purpose of my life? What is the meaning of my life? And how can I have my life best lived? But part of that answer to that question is a high degree of professional support, because without that professional support, patients with motor neurone disease often will start to develop significant symptoms. It's very hard to maintain a sense of life if you're overwhelmed by too much saliva, by thick saliva, by stumbling, by falling, by speech becoming difficult without anyone to help you. So I think as part of the answer to this question is the role of professional support. Now that professional support must involve a meticulous attention to detail. The talks this morning indicate how in various parts of the body motor neurone disease can affect. So we need to be really, like that reporter, looking very carefully at each patient and as professionals, and indeed each patient having the capacity to explain what's happening. It's not only my left foot, but it's also my saliva, it's also my swallowing. But we need to have a meticulous attention to detail. We need also, as health professionals, never to say, "I'm sorry, there's nothing more we can do." This frustrates me and my colleagues hugely when we hear any health professional say there's nothing more we can do. Absolutely not. Absolutely not. As a doctor, you don't hand in your MBBS simply because you're dealing with a patient now with motor neurone disease. You are the doctor for that patient all the way through, and every health professional. And indeed, quite the opposite occurs. There is so much that can be done. Small things, large things, things of physical things of the heart, things of the spirit that can be done. So the principle of non-abandonment is very important. So what are the needs of patients with motor neurone disease and their families and carers? Well, the period of the disease is marked by a progressive deterioration in function and capacity of the person, and often an increasing burden of care on the family of the patient. So their needs are physical, psychological, spiritual and financial. They're as broad as we are as human beings, aren't they? No single health professional can meet all these needs, so it does require many health professionals working together, and we come then to the role of the multidisciplinary team. You saw that great slide there from Dominic earlier. The role of the multidisciplinary team, not being a sense that this is something that might help or would be appropriate or would be ideal. I think it's essential. And the role of the multidisciplinary team, indeed, giving people extra time of life. the actual meticulous attention to detail, the care of patients, actually extending people's life. But it's more than the extension of the life. I think it's hopefully the richness of life, allowing some of those symptoms and issues to be dealt with so that each person can get on with the living. I think at the beginning, of course, is the role of the neurologist, and that's critical, making sure that we've actually got the right disease we're talking about. When it comes to speech and swallowing, we need to have the speech pathologist. So speech pathologist dealing with both speech and swallowing. Weakness of the muscles, well, that's going to be the role of the physiotherapist in terms of assessment, exercises, of course. The role of the occupational therapist in terms of equipment that may be needed. And again, working closely with their colleagues in physiotherapy. The role of the rehabilitation physician. So the team that we have at Calvary and Cogra having a close alliance with or member of our team being a rehabilitation specialist. I, as a palliative care specialist, know very little about orthotics or wheelchairs or extra equipment that could be presented, but he is able to come in and really help with our patients. Breathing difficulties, and of course that's the weakening of the chest wall muscles, and that's the role of the respiratory team in terms of how they may assess, and we've talked about the non-invasive ventilatory support, the BiPAP machine earlier. But there are other needs, of course, and these are deep needs of the heart and the spirit, the psychological, the spiritual, and indeed financial. The role of the social worker is critically important here in terms of addressing those needs, because it may be, as a patient or a carer, you have no idea about supports that may be possible. And indeed, the role of the New South Wales NMD Association, extremely important, and we encourage all of our patients to join. So this is a very broad sense, isn't it, at this team? With so many health professionals potentially involved, who is coordinating this process? Because you've got a lot of people doing their individual tasks, but ideally you have someone who's going to coordinate it. And really, usually it comes down to this person, extremely important, a motor neurone disease nurse coordinator who's going to have an eye on everything, keep us all organised, keep us on track, identify what's happening with Mrs. Jones or Mr. Smith, and making sure that things are being cared for well. That's really important. The role of the general practitioner is critical here. As Dominic said, that an average general practitioner may only see one or two in their working life of patients with motor neurone disease, but extremely important. That general practitioner may have known that person from their birth. They may have delivered that person. So it's that sense of the continuity and that general practitioner being there for the patient and the family through thick and thin. Palliative care, well, palliative care is extremely important. Palliative care is my discipline. Palliative care, I guess, is one of the myths about palliative care. It's all to do with cancer. Well, historically, yes, but no longer. In the modern era, at least a third of our work is non-malignant, including motor neurone disease. The other classic myth about palliative care, oh, it's just for the dying patient. Well, no, not at all. Our involvement should be much earlier in the trajectory of the illness, making sure that we're as meticulous as we can in terms of the physical, emotional, psychological, spiritual care of patients and their families. So it's a myth to say that palliative care is really just for the dying patient. So, and also, motor neurone disease is a quintessential disease that requires a palliative approach from diagnosis because it's life-limiting. So palliative care is all to do with life-limiting. So if you ever have a doctor or a nurse say, oh, we don't need to get palliative care involved because you're not yet at end stage, I'd be saying, well, actually, no, that's not true. Palliative care could certainly be helping me. And we're very happy in our service to be seeing patients at the time of diagnosis, any time from that point on. Unfortunately, too often the opposite occurs. There may be slow referral to palliative care, a fundamental misconception of the role of palliative care, belief that palliative care is simply care of the dying, not now, he's not ready for it. It will send the wrong message to her. Do not worry, it's okay. We're not going to trouble or upset patients. We're going to sit with patients and very gently explain to them our role, and that's important to know. I guess occasionally we might have this comment, certainly in the cancer context, occasionally in the context of motor neurone disease as well. There can be fear of morphine. Oh my God, the palliative care doctors are going to load us up with morphine. Well, we're doing nothing of the sort. We're going to, if we are to use morphine, it will be in very, very small doses, if at all. Health professionals feeling undereducated and underskilled. This is a critical issue. So we'll have a lot of doctors and for generations, doctors have graduated without any experience of palliative care. So I think it's very important even to senior neurologists and senior people to make sure that they understand the role of palliative care. Without coordination, the professional response to the trajectory of the illness may be chaotic and add hugely to the distress of the patient and the family. This is probably one of the most important slides in this talk. The professional response to the trajectory may be chaotic. In other words, no one's coordinating, no one's taking charge. The patient and the family are not sure who to contact. It's just getting it's becoming more and more difficult over time. The best approach, to me, would be a clear, systematic and planned approach, sitting with patients and carefully and gently going through exactly what is expected, what we're going to do, how we can help. So let's quickly move through some of these physical issues. Speech and swallowing, breathing, weakness of arm, legs and trunk and other issues. First of all, the swallowing, well, it's to do with weakness of the swallowing muscles. So we organise a speech pathology review. Usually, if it's showing that there's a speech a swallowing issue, we'll then add thickeners to liquids. Thickened pureed foods are often used. We talk about the insertion of a PEG tube. That's a tube that's placed into the stomach so that the persons can feed. If it gets to the point where they cannot feed safely here, it may be, now it's not for everyone, but it's something to talk about. And why do we talk about it early? We talk about it early while the person is fit enough for an anaesthetic. To actually put a PEG in, you need to have an anaesthetic, procedure to do it. And if you're not fit enough for an anaesthetic, the anaesthetist may say the person, it's just too late to do this. So it's best done while the respiratory function allows for a safe anaesthetic. Once the PEG inserted, can use it whenever required. So it might be simply sitting there and you continue to eat and drink, but it's certainly, and then eventually maybe combining oral and PEG and finally using the PEG feeds. Secretion issues are really difficult, aren't they? Too much or too little. Too much as in very, very watery saliva, heavy saliva. Too little, dry. With the too much, it can be very watery or very thick. So it could be excessive, wet, drooling, it could be thick and tenacious, and it may be a combination of both. For excessive wet saliva, we use medicines like NDEP, and that's quite a useful medicine to try and reduce the amount of heavy saliva. Glycopyrrolate or Robinol is used, and that can be given via a nebulizer, so it goes straight around the mouth, and that can be very useful to dry the mouth if the saliva is too much. And Donatabs are also there. For difficult cases where there's pooling of saliva, resistance to the above, you may need Botox to the salivary glands, and Dominic Rowe, the speaker from earlier today, does Botox to our patients, and that can be very useful, just simply reducing the amount of saliva these salivary glands are producing, and in very, very difficult cases, even radiotherapy to salivary glands. What about very thick saliva, tenacious saliva? Well, there is some natural enzymes in some of the fruits that are very helpful to break up very thick saliva. One is in dark grape juice. So we ask the patient to freeze it, make it into blocks of chips of ice, break it up and have it sitting in the mouth, and that can be very useful. Pawpaw and papaya are also used. Normal saline or ordinary saltwater nebulizers, and mucomist is a very good medicine to break up thickened saliva called mucomist. What about dry mouth? This may be due to medications, sinus problems are more common in motor neurone disease, mouth breathing, or simply patients avoiding using any liquids. So we perhaps liquefy the meals a little bit and check the medications to see if this is not good. There is a drop also called pilocarpine, an eye drop that also you can put into the mouth, and that will stimulate saliva as well. Artificial saliva, as I talked about, lemon juice diluted is going to stimulate a bit of saliva. Pilocarpine mouthwash or biotin mouth products are very good for dry mouth. Okay, speech. This is really important. We need to be able to communicate as human beings. We need to say what we feel, how we feel. So we need to have some way of reaching beyond the verbal. So what's happening, of course, in the bulbar presentation, when bulbar is affected, you're starting to lose the capacity to speak clearly. And this is really important that we get in early and talk through. So speech pathology assessment and ongoing advice, and then progressive use of alternate means of communication, simply writing. But what if the hand is now weak? So we need to think through that. There is an increasing use of the iPad with an app on that iPad, and we have many patients using that. It comes up a keyboard and you press at the end of the message and out will come an electronic voice. Also the light writer is sometimes used as well. What about respiratory issues? These are breathing issues. Well, the breathing issues occur because you're getting progressive weakening of the chest muscles, and Dominic's spoken about this earlier. So you can get disturbed sleep, headache on waking, sleeping during the daytime, eventually a shortness of breath. Note that shortness of breath may not be happening originally. In fact, there's probably these other issues that are going to happen first up. But if they happen, and we ask every patient about waking with a headache, if it's a consistent issue, then we'll organise for them to see the respiratory team and have this study done, what they call a sleep study. So they analyse what's happening through the night with your breathing. And so if it looks as though this is now starting, then you're offered. Now, as Dominic said, it's not compulsory. It's a matter of talking through with this patient a BiPAP machine that's usually put on overnight. It may go on overnight to maybe 2 or 3 hours in the afternoon, and then it may be that the patient is now using it all the time. So the BiPAP machine. With worsening shortness of breath, you may need to use very, very small dose of morphine and another medicine called lorazepam. Now, these are minute doses. These are not doses that are going to make you drowsy, and the doses can be used incrementally. And used appropriately, these medications won't hasten death. There's often a fear that if I even look at the word morphine, I'm going to pass away. Well, no. I think small doses of morphine in gentle doses with the appropriate titration are completely safe. What about peripheral weakness? Well, the involvement of physiotherapists is crucial. Regular exercise of muscle groups, orthotics, aids for mobilisation, walking sticks to wheelchairs. Pain sometimes comes into the situation, particularly if you're bed-bound or pressure sores or stiff, that may be. There is a higher incidence of reflux or heartburn, so to let the doctor know about that. Constipation, yes, a lot can be simply because you're lying still for long periods. Swelling in the feet is quite common as well. Psychological. Well, I guess the psychological aspects, first of all, is the shock of the diagnosis. And this can be very profound. What do you mean, doctor? We're in the 21st century here, and you're talking about an incurable illness, and you're saying that there is only one medicine that has been shown to be a benefit? What does this mean? I don't understand what you're saying here. So there can be quite a profound sense of the implications of the disease and what people are going to go through. Depression, yes, depression does occur and there's an increased incidence. So if you as a patient or as a family member are observing that the person is becoming very, very low in their mood and is not responding normally to humour or to normal things, then talk to your doctor about that. Patients can become quite easily emotional, and that can be that's often the case, but it varies a lot, and it can be difficult for carers where the patient suddenly is very strongly emotional about things. There is 5 to 10% of motor neurone disease have a dementia, a frontotemporal dementia, and that can affect your ability to coordinate what you're doing, your personality. You become disinhibited, so you're doing things that are perhaps a little bit unusual, those sort of things. But look, that's it's as you can see, a small percentage only, and that's there. There can be some degree of cognitive impairment, planning and capacity to accept change can be quite common, that difficulty there. Fearing of being dependent, fearing of burdening the family and carers, and fearing of choking to death certainly can come. Choking never occurs. That's a myth that people die of choking to death. They don't. Okay, where does hope lie in motor neurone disease? Because hope is intrinsic to us as human beings, the sense of what the future is going to be. If we only respond, well, there's no hope, then that makes no sense to any human being. Human beings are looking towards a better future. So where does my hope lie? So hope. Well, I guess you're starting to perhaps shift the focus of care, the focus of hope. It may be words such as these are used. I agree that there's no hope for cure, but that there is hope in other areas. There is hope that you'll be comfortable and supported throughout. that you will be not, that the hope is that you will not be abandoned, that you'll always be listened to, that all your symptoms will be treated to the best of our ability, that you will not needlessly suffer, and that you'll be treated with respect and dignity at all times. These are very important points, aren't they? The sense of what hope is. Not that you will never suffer, because we cannot guarantee perfection, but we're going to do our very best to make sure that you're okay. I encourage junior doctors to say these words to every patient with an illness, because it can be the entire hope is cure. The entire hope that this disease goes. Yes, there is that hope, but there is other elements, other parts of hope that are very important. There are now two things that become very important when anyone has motor neurone disease. The first is dignity. And a lot of what I've said is to do with dignity, to make sure that the person is being supported and cared for and looked after. But the other aspect is this, isn't it? The sense of love, the sense of what life is, the sense of intimate relationships, those deeper aspects for all of us. And I suppose this is nicely captured because often it's interesting as time goes on, people, carers and patients, the normal preoccupations of life start to fade, and it comes down to those two issues, dignity and love. And this is perhaps captured in this beautiful piece from an Arabic poet. Dignity. The expression is, but look at me, I've lost everything. A year ago I could do the lot, but more and more I rely on my wife. There is no dignity here in this. So what does that mean, the sense of dignity? I think in response to that, we need as health professionals to acknowledge the changes. We cannot dismiss it. It's very clear and it's very evident that these changes occur. And an appreciation of the enormous frustrations people are going through. And I say often these words or similar words, the disease has done many things to you and will continue to do so, but it cannot take away who you are, your core. That is untouchable. Your life before these times, your spirit, your humour, your grace and love, all of that is unique to you, and all of that is untouchable. Yes, the disease is taking so much, but there's something that's untouchable in your core. Love in all its manifestations, of course. And I suppose it could be simply, what do you love about life? Can this be preserved in some way? Is there some way of keeping this going at some point? And all of the above discussions will need the full involvement and support of the carers. And I guess we're doing this as patients, as carers, as health professionals, aren't we? On July the 4th, 1939, Independence Day for the United States, was proclaimed Lou Gehrig's Day. Over 60,000 people attended New York Stadium. Lou Gehrig spoke. It became known as one of the great speeches, really. It was an impromptu speech, but I'll just quote a little bit of it. Fans, for the past 2 weeks you have been reading about the bad break I've got. Yet today I consider myself the luckiest man on the face of the earth. I have been in ballparks for 17 years have never received anything but kindness and encouragement from you fans. He then describes his manager and his coaches. He concludes, when the New York Giants, a team that you would give your right arm to beat and vice versa, sends you a gift, that's something. When everybody down to the groundskeepers and those boys in white coats remembers you with trophies, that's something. When you have a wonderful mother-in-law who takes sides with you and squabbles with her own daughter, that's something. When you have a father and mother who work all their lives so that you can have an education and build your body, it's a blessing. When you have a wife who has been a tower of strength and shown more courage than you dreamed existed, That's the finest I know. So I enclose in saying that I might have had a bad break, but I have an awful lot to live for. Thank you. NMD, yes. The words are remarkable. The fame of Lou Gehrig's as a baseballer, but certainly that speech, which was broadcast throughout the United States, imprinted him forever on this disease, and even during his lifetime it was known as Lou Gehrig's disease. If anyone is interested, I've written a commentary on his life and what he went through, and I'd be very happy to give copies through to people. In conclusion, motor neurone disease challenges all who experience it. Maintaining and fostering a sense of life is vital. One aspect of this is the clear, systematic and planned approach by professionals. For this to occur, a multidisciplinary team is optimal. Complications and progression needs to be anticipated, discussed and planned for. There is always something that can be done. Our spirits, as well as our bodies, need nurturing. Thank you.